Hi, everybody, and welcome to our discussion on stem cell transplant in cutaneous lymphoma. I'm Susan Thornton, the CEO of the Cutaneous Lymphoma Foundation, and today I'd like to welcome Dr. Jasmine Zain, who is the director of the T-cell lymphoma program at City of Hope and a cutaneous lymphoma clinical specialist and also a transplant specialist. So thank you, Dr. Zain, for joining us today for our conversation.
Good morning. Yes, and welcome. I'm happy to be here today. Happy to answer your questions. Looking forward to a very productive session. Hopefully, we can give some good information to our patients.
Yes, and I think, stem cell, and I know in your experience over all these years in working with cutaneous lymphoma patients, this is always a big question. And maybe we can start by just providing a little bit of context in kind of the overall treatment landscape of cutaneous lymphomas. Where does the stem cell transplant therapy fit into kind of that continuum? I know for so many patients, they hear, oh, stem cell is the be-all, end-all cure, right, for cutaneous lymphoma. But the reality is, and I'll let you answer this question, but it really has a very special place within the grand scheme of all the different subtypes and stages and so forth. So maybe we can start there, and then we'll dive into some of the specifics around transplant.
Sure. So, stem cell transplant is a complicated process, and there are several types of stem cell transplant, which we can discuss in a minute. But generally, if you look at the overall treatment landscape of cutaneous lymphomas of all different subtypes, it's really one of the treatments that's considered that we would only consider in a life-threatening situation towards, when the disease is very advanced, or if you have failed other lines of therapy. Now, when we talk about cutaneous lymphomas, the first thing the patients read about or learn about it is it's incurable, right? So they really get scared. This is never going to get cured. And I always reassure my patients that cure is sort of a relative term in some ways. I mean, there's many diseases in this world that are not curable, but very treatable. And you have to think of cutaneous lymphoma as something very similar. We have lots of treatments. And so, we should not focus on curing, but sort of improving your quality of life and, getting rid of your symptoms and treating your disease. At the moment, there's going to be recurrences. They do hear that stem cell transplant is the only curative option. And I think that's where they start to get, want to get more information, thinking that would be the sort of the answer to this incurable disease question. But in reality, it's a very aggressive approach. I tell patients in some ways it's life-changing, because the complications and the requirements to go through a stem cell transplant, and then all the aftercare, and to be a stem cell transplant survivor is, it requires a lot of medical expertise, and there's a lot involved in that, and it it's not like a one-time thing. You come in, do it, and it's done. You live with that for the rest of your life. So it's something that we only consider in end-stage patients, in the sense that where nothing else is available, the disease is very advanced and potentially life-threatening, like maybe there's an organ that's being affected, a vital organ, or there's multiple tumors that have now stopped responding to other treatments. So that's kind of where we think about a stem cell transplant. It is something that's performed in specialized centers, and we always list it as a treatment option for cutaneous lymphomas, but really, in reality, very few patients actually qualify for stem cell transplant at the end of the day, because we have so many other treatments that are less dangerous or less toxic that we can offer our patients.
And just so that anyone that's watching knows the difference between the different types of currently available stem cell transplant, we're not going to talk about what might be coming down the future. We'll just concentrate on what we have today. So kind of the difference between the two different ones.
Sure. So, the first thing I want to clarify is a lot of people come to me and say, well, I've heard about a bone marrow transplant, and you're talking about a stem cell transplant. So the first clarification I want to make is that they're really the same thing. The bone marrow transplant really was the original term, because the stem cells that we are talking about were procured by doing, from the bone marrow, but now it's called stem cell transplant. It's the same thing. We can actually procure those stem cells from peripheral blood. We don't have to actually dig into the bone marrow to get them. These stem cells are the cells that live in our bone marrow and make our blood components on a daily basis. These are not the stem cells that people talk about in terms of the embryonic world or in stem cell research where for organ development, etc. These are our hematopoietic stem cells living in our bone marrow, constantly renewing our blood supply. So that's where, that's the origin of this term. There are two major subtypes of stem cell transplant, and really depends on the source of your stem cell or where they're coming from. So if the stem cells are procured from the patient's own bone marrow, or their own self, it's called an autologous stem cell transplant. That is done in some cases of, a lot of it is done in multiple myeloma. A lot of the time, some lymphoma patients undergo a stem cell transplant that is autologous. But for cutaneous lymphomas, it's really not been very helpful. And most people don't do well after an autologous stem cell transplant if they have a cutaneous lymphoma. The other type is where you get the stem cells from a different donor. And that's called an allogeneic stem cell transplant. Now, this is where you have to do tissue typing and look for a donor. We want to try to find a donor within the family that would be a sibling donor. And to get to that point, the important thing is not the blood group, not the sex of the donor, but rather what we call HLA typing. So there are these genes called HLA, or proteins called HLA proteins that are expressed in our cells that are important for accepting foreign tissue, if you want to put it simplistically. And these are present on chromosome 6. There are about 12 points on chromosome 6 that have to match between the donor and the recipient for the recipient, the patient, to accept this tissue from the donor. So we have to do what's called tissue typing or HLA typing, and your best chances of having somebody matched on those 12 points is usually your sibling. There's about a 25% chance that each of your siblings, if you have, may match with you because you have the same parents and you inherit different genes from different parents, but you may inherit the same group of genes from that are HLA genes from, between the siblings. If you don't have a sibling match, then we go to an unrelated donor. There are people who have volunteered to give their stem cells to patients. So there's a registry, it's an anonymous registry. We can send the patient's HLA typing into a computer and they can try to match it with a potential donor. Usually they have to be of the same racial or ethnic background, but they could be an unrelated person, different sex, different family. But if they match on those 12 points, bam, you've got a match. There's other testing that's done to make sure there's no infectious disease complications, etc. And then if the donor is safe to donate, we get stem cells from them. If that doesn't fail, and the more recent development in this, two recent developments in the stem cell source, one has been cord blood stem cells. And people do ask me about that. I have a granddaughter, a grandchild expected, and can I use their stem cells? And yes, there are transplants done with cord blood, and it doesn't have to be a relative. The advantage of a cord blood is it's banked. Again, people volunteer these cord stem cells. They require less than the perfect matching, and you could certainly use that. But for that, you need because cord babies are small, the number of stem cells that the cord provides is small. So usually this is more important in pediatrics, but we've certainly have had experience with cord blood samples as well. It doesn't have to be a family. So I wouldn't recommend that patients actually go ahead and bank their potential, baby in the families, their cord blood, because it's not really helpful. There are banks that have these available if needed. And we actually don't prefer that very much in an adult. And then there is the option of what's called an haploidentical transplant, where you can actually take the stem cells from somebody who's not a full match, but is a half match, like a parent or a child. And now we have the ability to use those potential donors as a donor for the stem cells as well. So those are the big differences. Autologous is self, and allogeneic is from a different donor, whether it's a sibling or an unrelated or a haplo donor. So that's the main difference between these. And so for cutaneous lymphomas, the transplant that works is an allogeneic stem cell transplant.
Great. That's very comprehensive. Thank you for laying all that out. I think that will be so helpful to people as they've heard all these different terms and
Mhm.
categorizing what's appropriate in the cutaneous lymphoma world.
Sure.
So let's kind of go back to where does this discussion, you talked a little bit in our opening about, stem cell really applies to a more advanced and aggressive
Mhm.
patient that has perhaps failed the different therapies that are currently available and so
Mhm.
forth. And I know in talking with other folks, it's that balance. When do you start the conversation about transplant for someone? And there's all kinds of iterations, as you said, trying to find the donor and all of those things. When does that, in your experience, come into play to start thinking about the possibility, whether you kind of go down that road or not, but when does that begin to be part of a conversation?
That's a great question, and I wish I had a good answer for that. It really it really depends on where you're being treated and who your treatment team is. So, for example, in areas where you have a multidisciplinary team, for example, at City of Hope, you have Stanford, where you have a dermatologist and a hematologist and maybe a radiation oncologist as well, taking care of uh, all patients with cutaneous lymphoma, because all these modalities come into play. It's a slightly different conversation. Stem cell transplantation is performed at transplant centers, so it's not something that will be available to in your clinics or everywhere. So if your treatment center has access to a transplant center, then or they're part of a transplant center, then that conversation starts a little bit earlier. Usually, once the dermatologists in the team feel that skin-directed therapies are failing or are not enough, they will refer the patient to a hematologist or an oncologist, depending on where you're being treated. These are, again, terms that can be a bit confusing, but both sets of physicians treat these diseases, so they will be treated then with what's called systemic therapies, or potentially even chemotherapy, and they can then initiate this conversation, because eventually the person who would be referring somebody for a stem cell transplant would be the oncologist or the hematologist on the team. When they start to feel that either the disease is getting more aggressive, there's tumors that keep popping up, are not responding to the current treatment, or if there's obviously organ involvement, and by organ I mean not blood, because blood involvement, that's Sézary syndrome, and that's usually not, you can have a little bit of blood involvement even in early stages disease, so that's not the whole indication of going to a stem cell transplant. But usually, in my experience, once you have tumor stage disease, or once you have extensive plaques that are just not responding to anything or fail to respond to treatments, or if you have organ involvement, is when you would start really, when you would want to refer the patient for at least a transplant evaluation. Now, in terms of when to initiate this conversation, I actually tend to do that pretty early on in the patient's decision tree, mostly to put their minds at rest. I mean, because when they will you go to the internet and they will read things, then they will read about stem cell transplant, they will be curious about, why is my doctor not talking about this? Or why hasn't this been offered to you if this is the curative therapy? So I bring it up early on, and I say, listen, this is, these are our treatment options. These are skin-directed treatments that our dermatologist will offer, and I'll work with them, and we can do we have lots of biologic and immunologic therapies. But if the situation arises where, where we feel that things are getting more aggressive, or and I'm starting to now need chemotherapy, which is far, far ahead in the future somewhere, or very few percentage of people will need it, that's when we may need to talk about transplant. But let me just tell you a little bit about it, and the fact that it's got a bunch of complications, and this is not something that we anticipate most patients with cutaneous lymphoma would need. So that's what I do. But I think most oncologists, once they get these patients, tend to bring this up. But one of the things that we're lacking in the field is uniformity of when these discussions should really be initiated in a more standardized way, so that they're not left to sort of have a uniform way in the sense that most patients are treated in the same way and get the same information. Or maybe the society can have some guidelines. We are definitely lacking that, but my experience has been to try to bring it up early, but let them know that it really is not needed. I mean, in the last 5 years, I have transplanted maybe 2 patients, and I see a lot of cutaneous lymphoma patients. So we have a lot of new good therapies that can avoid some of those complications that can, that are the result of a stem cell transplant.
Right. That's a great point. And I think to kind of emphasize what you said, that especially for cutaneous lymphoma, it's really important to be at a center. And if you find yourself in this place of having more challenging and aggressive disease, to be seen at that kind of a center that has options to offer, stem cell being one, but potentially clinical trials or other newer therapies that may not necessarily be available at even a local oncology or cancer center. So I think that's an important point, even if it's just a second opinion, right? To have that in your back pocket, and yeah.
And then, there's certain transplant centers where there's more experience with cutaneous lymphomas, because that the stem cell transplant for cutaneous lymphoma is a little bit different than other diseases like leukemia, multiple myeloma, or even systemic lymphomas, because you have the skin barrier, which is a very important infection control system in our bodies, which is compromised. So those transplants are a little bit special, and so there are specific centers that have more experience with it, and so it's best to try to find some of those places, and I think, Susan, your organization is very helpful in identifying those centers for patients, so I think that's an important point as well.
Yeah, and it's a small percentage, right? So and it's as you said, it's a complicated treatment therapy, or a whole thing that you have to go through. So it's important to find the right place, which I think is critical. And then that's challenging from a geography perspective. But I guess then, that kind of takes us down the road. If you get to that point where you're looking at the transplant as your next option, when you're speaking to patients and their care partners, what kind of counsel do you provide? It's a big decision, but there's all kinds of other components with regards to timeline, and, to your point, the right center, and people may come from far away. So how do you kind of help support people as they're walking through the decision and the requirements, both kind of pre-transplant, transplant, and then we'll talk a little bit about post-transplant and what that might look like. Some thoughts around that.
Yeah, absolutely. So that's, again, a very, very important part of it. This is not, sometimes I get patients referred to me, they come and say, well, we were sent here for transplant, and they're, it's like a regular visit. And I tell them, we're not going to accomplish a lot in the first visit. I can just give you an overview. There's a lot of information. So the transplant is, in my opinion, life-changing. It's one of those life-changing therapies, and it doesn't involve the patient alone. It's the whole family that's going to get affected. So the first thing to assess is the very first thing is, do we have a donor, right? So the first thing is, once you're starting to think about a transplant, you send out tissue typing and you start working on trying to find a donor. While that is happening, it takes a lot of time to really counsel patients, books, movies, movies about stem cell transplant, videos, and, just a lot of information, website links, things like that. All of this is needed to really get them to understand and grasp the enormity of this process. I really can't explain all of it in 1 hour to the patient. So it really does take a lot of time. And we have teams of people who will support that. So usually there's a transplant coordinator assigned to the patient once we're down that path. So there's a lot of counseling involved. The patient, we have to let them know what the medical needs are, right? So the patient has to have adequate organ function, cardiac, lung, renal, particularly adequate bone marrow, reserves, etc. So that's one step. Then we have a psychosocial evaluation, where the patient meets with in most transplant centers has to meet with a social worker, where they assess their financial situation. The patient is going to have to go get off of work or be on disability, at least I say for a year. It may take longer. If it's, if they recover sooner, they can certainly, we can help them go back to work, but I request at least a year of work. There has to be a caretaker, and then they have to understand the complications and the process. The process is, you can explain, because they feel like this is something they can go through. There's the process of stem cell. Well, the procurement is going to be from the donor center, but they will need some kind of chemotherapy, maybe a little bit of radiation to the skin. So that's called the conditioning regimen. So they have to go through that. And then there is the process of allowing the graft to stay. So they have to be immunosuppressed, and that's the function of the chemo or radiation therapy. Then they have to be on medications to prevent the graft from fighting their body, which is called graft versus host disease. So that those medications, we've got to counsel them about that, the symptoms of graft versus host disease, acute, chronic, all of that. Then I also explained to them that there is, what all these medications do. They affect organs. They can affect your kidney function. Your immune system is weak, so you'll be immunosuppressed. You'll be at risk for infections. What kind of care they're going to need to prevent infections. They'll need to be on antibiotics and antimicrobials to prevent infections. There may be financial issues about getting some of those medicines that can be pretty expensive. And then finally, the thing to counsel about, which is most important, is what is it going to do to your disease and the expectation. So even though this is considered curative, an allogeneic stem cell transplant, in my experience, a lot of people still relapse, especially if they have tumor stage disease, and may need some therapy even after the transplant. So what I tell them, their disease will be modified. It will become more manageable, perhaps, would be the best case scenario. It's also possible that nothing ever comes back, but they may still have rashes here and there, and they will be grappling with issues with graft versus host disease as well, and may need therapy after that. So trying to explain all of this in an hour is not easy. And also, I think it's very hard for people to comprehend that. I always tell patients to bring their partner with them. I mean, of course, with COVID, it had been a bit difficult, but we're relaxing those restrictions. Ask lots of questions, take lots of notes, and then we'll have several other meetings about this. And this whole thing will be reiterated over and over again with the transplant coordinator, the social worker, subsequent visits with the physician while they're preparing for and getting ready for the transplant. It's a huge financial burden on the family because you have to be on disability. The medications are expensive. You may need a caretaker, so your partner may have to take time off of work as well. So family leave, all of that. And then the care, we expect, if you're coming from far away, that the expectation is, or we tell them right away, that you'll have to stay close to the transplant center for the first 100 days, which is the first 3 months post-transplant. If after that you have recovered enough, we can send you back to your treating physician or closer to home, another hematologist, oncologist who's comfortable with taking care of transplant patients, and then you co-manage with them any complications that occur, and just continue to monitor for signs of infection, graft versus host disease, etc. And this goes on and on for a while, till the body really gets used to the new immune system, the new stem cells that have formed the new immune system in the body. Could take several months to years sometimes. Fortunately, we have new medicines for graft versus host disease as well, and better antimicrobial therapies. So the outcomes of transplants are also getting better. So there is, but this is a lot to comprehend for somebody, I think, on their first visit. So that's why, you need all the help you can get to try to make them understand what they have to go through, and then ask lots of questions. And, then I give them links to your foundation. We have the BMT Infonet, just to get familiar with all these different terms. And that's kind of how the whole process goes. So
yeah,
I think
that's great. And
one last thing, I think what I find is, this is more of a philosophical thing, that people don't really get it till they have the transplant. It's really, really hard to convey all the different aspects that you have to juggle to get somebody through. And then I think the best thing is if we can get the patients to meet with somebody who's had a transplant, if somebody agrees, and support groups, those are really very helpful for them to really understand what their life is going to be like post-transplant. So.
Yeah, thank you. I think this is a great start to be able to highlight some of these things way early for people that may never need a transplant, but to just get a sense of what it entails, and sort of the gravity of making this kind of a decision and what that all looks like. And, we're doing a series on transplant because it's one of those areas, doesn't impact most of our patient community, but for those that it may, hopefully this will provide folks with some understanding and insight. To your point, maybe before they get to that first potential meeting, they've got some grounding, at least terminology and
Right.
appreciation for the timeline. It's probably, you were saying, post-transplant like a year, but probably even pre-transplant, all said and done, you're talking at least a good 6 months, assuming
6
that
months.
you can get to
Yeah.
a donor. And then,
Right.
I know we've had stories of people that had a donor, then they didn't have the donor, or,
Right.
and things can get kind of complicated that way as well. So it's not, there's a lot involved. And yeah, so
Right.
hopefully this will help maybe set a little of those expectations and answer some just preliminary questions for folks,
Right.
as they may have to grapple with this kind of a decision. And I guess looking at post-transplant, you talked a little bit about, the critical nature of those 100 days and really needing to stay close to the transplant center. I know several patients that I've engaged with, they get an apartment kind of on the campus or close by. And so if something happens, they're right there and can be seen and monitored. And that's really, really important. But then, for that next year, you're really still in that process. And so many different things can occur. Anything specific that you encounter in cutaneous lymphomas that maybe others in other types of transplants don't? I think for us, the skin component is always a little bit of a trickier piece.
Absolutely. So, for a skin disease, having graft versus host disease that involves the skin is really difficult to it's a difficult situation. So we have a patient who's grappled with the skin problem, which is primarily a skin lymphoma, for some period of time before the transplant. And now they've had the transplant, the skin has cleared, they're happy, and now you start to have graft versus host disease, which is another skin. It could manifest itself in the skin, which is one of the more common organs. It could also involve the intestinal tract, liver, bone marrow, but most patients will present with skin rashes. And so the biggest challenge is, are we dealing with disease relapse? Are we dealing with graft versus host disease? And a patch of graft versus host disease could, especially a patient who's experienced it, may look very much like a skin, a relapse of their lymphoma. And if you look at the pathology, if you just do a biopsy, it basically just shows inflammation, it's sometimes difficult to distinguish between the two, but that would be the best way really to determine if this is a graft versus host disease or skin lymphoma, because the treatments at that point would be very different. If the patient's disease is relapsing, the first thing we would do is we would pull back on the medications that are suppressing the graft versus, the immunosuppressive medications. If it's graft versus host disease, we have to do the opposite. We have to suppress the new graft further. So the treatments are actually completely opposite. So that's one of the bigger challenges of the patients with cutaneous lymphoma who undergo an allogeneic transplant. It's also disappointing for them because they feel like their skin has now recovered and they don't have to deal with this. And now they're starting to have this issue again in a different setting. That's really the biggest difference between a transplant for cutaneous lymphoma and other diseases. Unfortunately, sometimes both occur together. I've had patients where there's a few patches that are cutaneous lymphoma and the rest is graft versus host disease. And so, that's where the balancing or art of medicine comes in, where you have to really figure out which way to go and how to adjust the medications to affect. The good news is that if you have relapse after an allogeneic transplant, there are ways to manipulate what we call the graft. We can withdraw the immunosuppression or lower it, and and the graft can kick back in and take care of the lymphoma, or we can strengthen the graft if it's weak. So there's things we can do post transplant if the disease starts to relapse, especially early on, to make sure that the graft versus lymphoma effect persists, which is what we're aiming for, that the graft fights the cancer lymphoma.
Yeah. So again, another reason, why you need to stay close by your center so that these things can be monitored and managed until you get to the point where you're in good enough shape to go farther away. And, I guess, let's see, I think we covered a lot. This is a lot of great, basic information for folks who maybe have thought about it or heard about it, or, hopefully don't ever have to go that way, but at least it gives some good context on what this all means when you talk about stem cell. Is there anything else kind of in our final minutes here that you might like to share with the patient community about stem cell and cutaneous lymphoma, or words of wisdom based on your experience that we can leave?
I don't know. I don't know if I have any wisdom. I just hope that we can find better cures for our patients so they really don't have to go through this allogeneic stem cell transplant, which in my mind is really the last resort to save somebody's life. And, somebody who presents with a patch or a plaque, to them, this seems really, really far away. But as you know, this disease can have many variable manifestations. And certainly for that small number of patients where it is truly the disease is not being controlled, I can tell you stem cell transplants have saved lives as well. In spite of the fact that I have perhaps scared people with my conversation, but it is also a life-saving procedure for those who need it. So that's something to keep in. And the job of the physician and the transplanter is to find that right balance where you actually are going to benefit somebody, and offer them the stem cell transplant and have them go through with it. You don't want to do it too early, and give them all those complications. And you also don't want to wait too long where it's too late to do it. So it is life-saving, but fortunately only for a few, it's needed for only very few patients in cutaneous lymphomas. And so I'm grateful we have this opportunity to offer to our patients at this point. But I hope that one, transplants get safer and better, and two, we have better therapies. And one last thing I want people to think about is that the reason we do a stem cell transplant, an allogeneic stem cell transplant, is really to give them a new immune system. So it is a kind of immunotherapy. So this is old-fashioned immunotherapy. Before we knew what it really was, it was developed at that point. But now we are, there's a lot more, there's bispecific antibodies and CAR-Ts, and all of these things are being developed, which will hopefully replace and be better able to harness our own immune systems to fight cancers, rather than having to do this elaborate procedure of an allogeneic stem cell transplant. So those are my last words, I guess.
Well, very, very well said. And we really appreciate your taking the time and bringing your knowledge and wisdom to the patient community on this very specific topic that I think gets misunderstood a lot. And I think this will really help folks figure out where they may be in the continuum and give everyone some basic appreciation and understanding. And to your point, as we go down the road here with the new therapies and we learn more and more about how our immune systems work and have targeted therapies, that maybe someday this version of stem cell will be in the past. But thank you so much for joining us. And we always love having you with us, and your knowledge and wisdom is deeply, deeply appreciated. And your work with the patients Yeah,
Yeah.
the team out there is just extraordinary. And thank you for your commitment and dedication, because it's a lot of work. So thank you so much,
Welcome. It's
Dr.
my
Zain.
pleasure. It was my pleasure.
Yeah, have a
Absolutely.
great day. Thank you,
Thank you. You
everybody.
too. Thank you. You too.